this morning, though, the Bureau of Labor Statistics released the worst monthly jobs report in American history. In April, the United States lost a record 20.5 million jobs, with our national unemployment rate reaching 14.5%, the worst since the Great Depression. In the 2 short months since the coronavirus has turned our lives upside down, it's not only become the leading cause of death in the United States, it has wiped out an entire decade of job growth. As we've discussed in recent weeks, the Federal Pandemic Unemployment Compensation Plan provides an additional $600 per week to individuals who have lost their jobs as a result of the COVID-19 pandemic. This is one of 3 new federal programs requiring a significant addition to our current unemployment insurance system. The Kansas Department of Labor has already paid out over 200,000 of these $600 payments. The retroactive payments began processing on May 6, 2020, 3 days ahead of schedule. I urge Kansans who qualify to apply online at getkansasbenefits.gov on the day that corresponds with the first initial of their last name. That would be A through G on Sundays, H through M on Mondays, N through S on Tuesdays, and T through Z on Wednesday. And I'll go over that again. A through G on Sunday, H through M on Monday, N through S on Tuesday, and T through Z on Wednesday. Doing it this way will expedite the process. I know that this crisis has been so very difficult for everyone, but particularly those who are unemployed now here in Kansas. Please know that the team at Labor continues to work around the clock to provide the best possible services during this extraordinarily challenging time. We will have a much more comprehensive labor update next week. Throughout state government, efforts are in place to ease the burden for Kansans experiencing difficulties in so many different ways. It's important that we remember this crisis is affecting Kansans of all ages. When we talk about our overall health and well-being, we must also acknowledge the effect of this time on our youngest and our most vulnerable children, and the role early childhood programs play in their development and success. We're pleased to announce today that our state has been awarded an $8.9 million federal grant that will be used to strengthen our early childhood system. The grant was awarded by the Administration for Children and Families, a division of the Health and Human Services. It's the first installment of a 3-year renewable Kansas Preschool Development Grant, Birth Through 5 initiative. These funds will be used to keep up our current momentum as we work to improve our state's early childhood system. This grant is particularly welcome now as the COVID-19 pandemic has caused an additional level of stress for our young children and their families. Leaders from the Kansas Children's Cabinet, the Kansas Department of Education, the Kansas Department of Health and Environment, and the Kansas Department for Children and Families began this collaborative work with a program planning grant in January 2019. The initial grant funded included a comprehensive statewide needs assessment, which illuminated what Kansans need and want from their early child care system. Over 6,000 parents, early childhood professionals, civic and business leaders, and community members provided input. Addressing these findings from these efforts is the foundation of a new statewide strategic plan for early childhood finalized later this month. Funding this grant will support systems alignment, infrastructure, and innovation at the local and state level. Kansans can expect to see investments in activities that build a sustainable infrastructure for our early childhood system. Together, we'll march forward with this and not allow this unprecedented crisis to derail critical initiatives such as early childhood education. And with that, I'll turn it over to Dr. Lee Norman, Secretary, Kansas Department of Health and Environment.
Thank you, Governor Kelly. Today's COVID-19 numbers. We have 6,501 positive cases, which is an increase by 357 since yesterday, 40,276 negatives, and 152 deaths, which is an increase of 5 from yesterday. An important note about how we'll be reporting out numbers on our website, because there's going to be a change. To move into our state's reopening plan further, we need to ensure our critical epidemiology staff are used in the most efficient manner. Staff has spent about 10 hours each day preparing the daily reports that go online. We need to allow them to shift their focus to the local level. Our local health departments need help, and to work to ensure the local communities have the data they need to guide their reopening decisions. Beginning on Monday the 11th, we will do our data updates to our website will occur on Monday, Wednesday, and Friday. That way that we can spring free our precious epidemiology staff to do their work, which is actually to push down the disease and to assist in the tracing and amelioration of this disease. The state is currently monitoring 76 clusters that account for just short of half of the total number of cases, 2,861 cases with 101 deaths. The breakdown from the largest to smallest, 31 are in private companies, 378 cases with 4 deaths in private companies, 22 long-term care facilities with 540 cases, including 85 deaths, 8 churches and church-related gatherings for 111 cases and 8 deaths, 6 meatpacking plants with 1,082 cases and 2 deaths, 3 group living arrangements with 41 cases and 0 deaths, 3 in correctional facilities, Lansing Correctional Facility, Wichita Work Releases, and Grossman Center, 687 cases and 2 deaths, 3 in healthcare facilities representing 22 cases and 0 deaths. A note about Lansing: the testing of all inmates in Lansing Correctional Facility is complete. We still have some tabulating to do, but it appears that less than 50% of the inmates in Lansing have tested positive at this point in time. A reminder, with adequate testing across the state, if you are symptomatic, we encourage you to reach out to your healthcare provider for testing. We have sufficient testing materials for the symptomatic people throughout the state of Kansas. PPE, protective equipment. I want to do point out on this placard here, that is the device we now have at Forbes in one of our warehouses for the reprocessing of N95 masks. This is actually the one that we have in our facility here in Topeka. Who can use this service? This is a free service, is open to Kansas healthcare personnel who wear N95s as part of their work to protect themselves while performing healthcare associated services. The definition of a healthcare professional is outlined in Patel's emergency use authorization. This is one of 10 such devices around the country, and to put it into production and for our use required them to have an emergency use authorization, and that is what drives what and who can supply the masks to be pushed through there. And you can find the EUA, Emergency Use Authorization, can be found on FDA and Patel's websites. That includes hospitals, long-term care facilities, first responders, local public health agencies, and state of Kansas agencies. Not eligible agencies include any agency who wears the N95 respirator mask for non-healthcare associated purposes. In other words, chemical, pharmaceutical purposes, food safety, and supply. Again, we are doing this because we have a shortage of N95s and will continue to, and we want to make sure that the non-eligible agencies will be circumspect in what we would hope would not be the overuse of N95s, so that we assure that healthcare providers can get them, and first responders. If your healthcare agency would like to sign up, contact your local county emergency manager for more information. The run rate, and we've started to push them through now, the masks, will hopefully be a minimum of 10,000 per day, with the hopes of increasing to perhaps up to as many as 18,000 per day. Currently, the Patel unit is contracted to be with the state of Kansas for at least 6 months. We did not have to purchase it; it is provided to us at no cost, including with some staff. Again, for your healthcare and related agencies that I described earlier, if you're interested in signing up for how this decontamination service works, please contact your county emergency manager. Something that's interesting, I think, and will be helpful is wastewater detection of COVID-19 matter. KDHE and the University of Kansas School of Engineering have teamed up to determine if genetic remnants of the COVID-19 virus can be detected in wastewater. The answer is yes. While there is much to be refined and evaluated, this is promising. Samples were taken from large city and small towns throughout Kansas with multiple wastewater facilities and sampled, and the closest towns were in Lawrence and Topeka. The concept originated in Massachusetts and in the Netherlands and is now being used throughout the United States, and it's used to detect wastewater that has fragments of the genetic material from the virus shed through urine and feces. The genetic material can be extracted from wastewater and matched against genetic markers for COVID-19. The virus itself does not survive in wastewater, and it's a critical point. The virus itself does not survive in wastewater. Therefore, wastewater is not a means of disease transmission. Detecting genetic material in wastewater may give local health officials knowledge of how widespread it is in their community. And interestingly, what's been found in Massachusetts and in the Netherlands is that in communities where it's not been detected or has been detected and has dropped to zero, this can be an early marker even before people come up with either asymptomatic or symptomatic illness from the coronavirus, COVID-19. KDHE and KU are still evaluating the results and formulating plans for the next steps in using this detection method. I want to make clear this is not exactly ready for prime time yet in the state of Kansas, but we hope to be on the leading edge of this as an early marker for the longer haul as we go through this, to have it as an early indicator if there's any increase in the prevalence of the disease. That is the end of my prepared remarks.
Governor, there's been some discussion amongst legislators of when they come back on the 21st of doing a bill that deals with the legal liability, protecting businesses from lawsuits, healthcare providers, maybe even nursing homes. Do you have a position on that yet?
Well, I do know that the Medical Society and the trial lawyers are working on legislation to deal with the liability in those kinds in healthcare settings in particular, and I'm hoping that they will come to a mutually agreeable position on that and we'll get something done on sine die. In terms of the business liability, that is still something that lots of conversations are occurring about that. I think you know that Congress is also addressing that particular issue, so that's still in formation.
Governor, we're hearing from a lot of people that they're calling the Department of Labor and calling and calling and calling. There's no voicemail set up. There's no way to hold on the line. You just have to keep calling back, and they're not able to get through. What advice do you have for those people who are calling multiple times?
You know, I have not heard that before, so I will have to check. I have heard about extraordinarily long waits on the line to get through, and we know that that has occurred, that it continues to occur. It's not as bad as it used to be, but it still continues to be a problem. But I have not heard about the inability to wait for an answer.
Are we still on track for phase 2 of the reopening on the planned date, or is it too early to know?
It's too early to know. You know, that is, what, over a week away when that might kick in. So we'll obviously need to be tracking the data next week.
Governor, are you going to extend the property tax deadline?
You know, is that the May 10th deadline for local counties to collect property taxes? I think I've addressed that issue before, that I will wait on a recommendation from the Kansas Association of Counties regarding that, because you know, there are 105 counties and 105 different approaches that might want to be taken. So until they come up with a consensus approach, I'm going to leave it at the local level.
Yes, but Governor, I mean, given that the deadline is May 10th, which is Sunday, Mother's Day, if you wait much longer, the whole thing's going to be moot, isn't it?
Well, it very well could be, but as I've always said, I'm not going to make that decision for local units of government. If I was going to do anything, it would be at the direction and the recommendation of the Kansas Association of Counties.
Secretary, I wonder, with the device that sterilizes N95, I wonder what advice you have for example, nursing homes. I've heard from them, like, maybe you have a certain number of N95s and you're not using them yet just in case you're going to need them down the line later. Should they start loosening that up and using their stockpile, thinking, oh, we can reuse them, or should they still be very cautious?
Yeah, really great question. In other words, should we invoke the re-sterilization process now or wait until there's a worse crunch?
Yeah.
If I understand it.
Yeah.
And the answer is we should start re-sterilizing now, and nursing homes, hospitals, first responders, while the PPE supply chain is improving, we want it to not be a traditional 90-day cache in each facility and at the state. We want to have more than that. And the only way we're going to get to that, if we assume the current burn rate on PPE, and if we assume the current supply chain bringing materials into us, is to go through this reprocessing. And we're encouraging people to start organizations to start right now to reuse it, because we have every reason to believe that the reprocessed masks are every bit as effective if we follow the reprocessing guidelines as brand new ones. And let's, in time of war, prepare for peace. Let's stockpile more and more.
And how many times could they do this?
Up to 20 times.
20 times.
Mm-hmm.
Okay, and pardon my ignorance, but is Battelle a private company then?
Battelle is a nonprofit research organization.
Who are they linked with?
They are themselves.
Okay, they're not like linked to the communist Chinese?
No, well, I can't say that for sure. I think not.
Okay.
Governor, Senator Denning is no longer running for re-election. Do you expect this to have any impact on the Medicaid expansion compromise that was developed?
Well, I like to remain cautiously optimistic that maybe the legislature will come back and on sine die that they will pass Medicaid expansion as in recognition of Senator Denning's long service here in the legislature. But more realistically, I think it will not get passed this year. We'll move into next session. And I think the only thing that's going to make a difference in Medicaid expansion's outcome is the election of November.
And Governor, on that note, what do you think of Senator Denning not running again?
Well, I have no doubt that that was a very difficult decision for him to come to. I think Senator Denning really enjoyed being a state senator, put a lot of time and effort into that job, and made significant contributions here to the process. So I'm sure that this was not done lightly, but you know, we have to take into a lot of considerations, a lot of things into consideration when we decide to run for office. I'm sure he's done that and decided that this was the best way forward for himself.
Governor Kelly, how far along are we on the path to reopening state offices?
Well, we're moving along with the state offices, much like we're moving along with businesses and phasing in that. Most of our folks are still on, if they can telework, they're still teleworking. We're not bringing them back into the offices. We have a lot of state offices that don't lend themselves to good social distancing, so we'll continue that for as long as we need to. But so we'll just phase all of that in. I know that the Department of Revenue is looking at ways that they can reopen motor vehicle offices across the state and trying to put in the protective shields and the other kinds of things that they think they need to be able to do that.
Governor, the COVID deaths in Kansas, more than half of them are in nursing homes, and the experts I've spoken to have said that that could very well get worse because as Kansas reopens its economy, there's going to be even more risk that workers unknowingly take the virus into facilities. And in Kansas and elsewhere, those facilities don't have enough rapid testing and equipment to protect us here. What can we do to prevent nursing homes from paying a very dear price for Kansas reopening its economy.
Well, I think, as this pandemic developed, we put into place some pretty strict protocols in our nursing homes regarding visitation, regarding personal protective equipment, and regarding temperature screening, all that for staff. I don't see us relaxing much of that as we go forward for a pretty long time. And I know it's very difficult for people not to be able to go visit their loved ones in nursing homes, but it is a hot spot. Congregate living like that is a place where a virus like this can very easily spread. So we need to be extraordinarily careful. If we loosen up the restrictions at all, it will be very carefully approached.
Senator Norman, we're hearing out of New York that they might possibly be seeing some cases for people that have been quarantined and are at home. Do you know what would cause that, and is that a possibility for people in Kansas?
I don't know the exact cases you're asking about, but people that are in strict quarantine at home it would be very surprising to me that they would become infected without having an incursion by either somebody coming to the door, somebody handing an inanimate object that hasn't been properly washed off. For example, when we bring masks to this device here, they'll be double bagged, and the masks will be inside a bag and inside a bag. The outside of that bag is going to be sterilized with 70% alcohol, so that there's nothing that comes in on the fingertips. So it would be unlikely to come in by wind or by opening the door to check the mail. It would be more than likely somebody or on some kind of an inanimate object.
But I thought there was a CDC study of a restaurant in China where the air conditioning system was part of the issue in how it got from table to table, even though people were sitting distance apart.
Yeah, and John, the question I think it rephrased is, can the air handling contribute to the spread of the virus? And that is absolutely true. But it comes from somebody, gets into the air system, and goes to someplace else. That's always a threat. And I will say, as much as we do desire to go to zero risk, we'll never get to zero risk when it comes to the transmission of this virus. So what the question is, how do you get the most bang for the buck? How do you mitigate the risk to as low as possible? That was also true, by the way, in housing and apartment complexes where there'd been some do-it-yourself kind of lousy air handling remodels done through the time, because that was felt to be through epidemiologic tracking and case finding. The only way that it could have gone was through air handling. Curiously, and you didn't ask, but I'll say it anyway, yesterday I met on a Zoom meeting with about, I don't know, there was probably 15 panel members and 200 additional construction people, healthcare, hospital design folks, where we are exchanging ideas on what do I know about the illness, what do I know about its spread and transmission, what are they going to do to inculcate these design features, either to retrofit or in new construction to look for the long haul. I gave them a lot of credit. It was an hour and 15 minutes of give and take of the best science, the best epidemiology, and the best design. Really encouraging discussion, and it was to get to exactly that thing you're asking, John, which is anything sacred? And the answer is air handling has to be looked at really carefully.
I'm also curious, I recall that you said maybe a couple of weeks ago that there was a goal of testing all the residents of long-term care homes. Did that include staff, and where are you all on that?
Yeah, we've always focused, because of the limitation on our testing materials, on symptomatic individuals. We're doing more testing of asymptomatic persons now, and it's in exactly what you're asking, in congregate living arrangements, whether it's nursing homes, prisons, and that is, we are testing asymptomatic people across the board of the residents and the staff. Okay. And so we're getting a lot more information than for we've talked about hotspotting by county, by town, but now we can hotspot by individual and then start doing the classical ring contact tracing around that. But a lot of it relates to the asymptomatics.
But that would be tens of thousands of people, wouldn't
Yes, it is. We have hundreds of nursing homes alone. Most of them have not had any cases at all.
So wait, are we now testing asymptomatic people in nursing homes where there have been no known?
No, not,
You're
no.
talking about tracing.
Yes,
around
exactly.
Asymptomatic people around a known case.
Yes,
Okay.
where there's been a single case identified.
But you would like to get to the point where everybody in a nursing home or working in a nursing home could be tested.
Yes, that would be Valhalla. That would be the high ground if we could get there. But we're not there yet just because we don't have the throughput and the testing materials to do that. And we don't have the staff, quite honestly. So we just, by necessity, need to target.
Some of the experts I spoke to said the ideal is that we need rapid testing platforms at nursing homes
Yes.
on site. Is there anything that can be done to achieve that?
Well, we have point of care testing now. It can be, there's one called Cepheid, which is a 15-minute turnaround, and the Abbott platform is about a 45-minute turnaround. We have 18 of the Abbott platforms and a few of the Cepheids, and we would love that.
But
And
there are hundreds of long-term care facilities.
there are hundreds of, yeah, and I think that the future will hold that. Much like, you know, I remember the olden days when you had to go to a hospital or a doctor's office to get a pregnancy test. And now you can go down to Walgreens and get that, or any number of places. I shouldn't single out Walgreens. So we would love to have much broader, as long as it's very sensitive and specific, because it would not do any good to. It would be confusing to have a widely available test that had a high number of false positives and false negatives. You have to be able to believe the result.
What's the differentiation between the confirmed positive and then the probable positive cases that we're seeing?
Yes, great question. And if I get gray hair ever in this job, it will be around definitions. And the question you bring up is, confirmed are the tests that we do, and initially we had to have them confirmed by the CDC. So they were presumptive until they were confirmed by the CDC. That horse left the stable a long time ago because, one, the vast numbers, and the testing from the CDC platform is so good that all of our presumptives came back as confirmed. What you're asking about is probables, which is what happens if somebody doesn't have a PCR testing on the nasal swab, but they have a blood test that shows that they've had an antibody, which may be the coronavirus, COVID-19, and they may or may not have had symptoms. So the probable one, by definition of the CDC, is a positive serology test and the presence of symptoms can be a probable. And this is going to give people a lot of heartburn because they say, well, did I have it or not? And then it's not very gratifying to say, well, probably. And I made mention of my son in New York who had COVID-19. He never was positive. Sorry, he was never tested. There was no place in Brooklyn, New York to get tested unless you were in a hospital. Did he have onset of symptoms with the loss of taste, loss of smell, and everything else that was classical textbook? Yes. He's listed, I'm sure, someplace in the state of New York as probable. And I hope that people understand that we're trying to stick with a common definition platform as established by the CDC.
Well, why did you all start reporting the probable cases in like the county totals yesterday? What made the decision to do that? And then the argument, I mean, it's pretty much thought that there are far more cases than what everybody is reporting because of limited testing at first, and people can have it and not have any symptoms. Right?
Absolutely. You're absolutely right. There's much more COVID-19 out there than will ever be tested, and probably more than even will be considered as probable. The reason is because we're starting to do more serology testing statewide, nationwide, worldwide, and therefore that is factoring into how do you make a case definition. Because one of the things that is going to be really critical through time is epidemiologically speaking, how do we control this disease until which time we have specific medicines and vaccines, and that is by understanding data and how to interpret the data. So we're trying to get as crisp and accurate, and it's the serology that's driving this change in definition.
And I got to tell you, I don't like the idea that you're going to be doing numbers every other day instead of every day. How do you calculate daily stuff if you're not taking these counts?
We don't calculate, well.
I mean, you're doing rolling averages, right?
Yes, we are doing.
Case counts and all that.
And those rolling averages work if you display the data. We get the data 7 days a week, but in terms of I won't say scrubbing, in terms of validating the numbers and putting those into the 3-time-a-week graphs is quite honestly to help our epidemiology staff to spend more time doing the things to push down the number of cases, to case find, case investigate, and contact trace. A person really doesn't, and as much as I know that it's maybe desirable to see something every day and have it refreshed every day, when we're looking at rolling averages, we're looking at a week or 2 weeks rolling average without necessarily having daily spikes, daily valleys, peaks and valleys. I think it's a new normal that we'll get along with just fine.
With the serology, most of those tests still don't even have FDA emergency use authorization, right? So KDHE, do you have any way of vetting which serology results are worth looking at and which ones aren't? Or, I mean, there's just too much going on.
We do, the question is do we, how do we, and do we evaluate the serologies? And we do. As a matter of fact, what we want to do is have one that's incorporated into our testing strategy that is COVID-19 specific, because until that time, it doesn't do us very much good. You heard me mention 2 weeks ago today on a testing location in the state of Kansas that we had a difference of opinion with that was using a non-specific coronavirus antibody to tell people they're immune to COVID-19, which is just not accurate. We have to have it be COVID-19 specific.
But sorry, I think I'm confusing two things. When Kansas rolls out serology tests done by KDHE, I think what I heard you saying is that you'll be very careful about choosing which test you choose. But in terms of which cases across the state become listed as in that probable case count, because there are, providers all across the state that maybe are going to do serology tests. I'm guessing you guys can't vet what test all of them do.
Absolutely right. And we are working through it goes back to the case definition, and it goes back to our testing strategy. And we have to meet in the middle on this to get as accurate. And to be honest with you, as per your question, it's changing so quickly that we absolutely need to nail this down, and I think have it be with a more specific COVID-19, because I don't think that the non-specific serology is going to get us there with accurate information. We could test all of us in here, and some of us would be positive for the coronavirus antibody, and it wouldn't necessarily mean anything except that we had a cold sometime in our past.
I saw a presentation from an epidemiologist out of Minnesota who's currently worked for 4 or 5 presidential administrations. And in the presentation, he said something like, having no cases or a very low number of cases is like being in the eye of a hurricane, and that the back wall is going to hit harder than the front wall. What do you think of that assessment? That is how pandemics tend to act. You get through the first wave and then have a spike. In some pandemics in the last 100, 200 years, not plague, but there's been other ones that are 3 to 4 times the number of cases that you see in the first wave. The thing that I'm comforted with is that, and we've looked very carefully at hospital beds, ICU beds, ventilators, dialysis machines, and total med-surg beds, and even if we were to get to that number, which I'm hoping we won't, in Kansas or nationwide, we would have the capacity to take care of that now and to test for those people that are ill. But you're absolutely right, John, that it's kind of like no news. Is no news good news, or is just no news just no news? And unless you test and find out the true number of asymptomatics, whether it's through serology testing of high quality serology or for the PCR testing, we really don't know the burden of disease out there. But if we have the capacity to handle that bigger surge, then there's an argument out there that a stay-at-home order statewide for as long as Kansas did it wasn't necessary given the economic damage it did.
I don't think there was a question in there. I think that was a statement.
What do you think of that?
Oh.
Respond to that.
I was buying time. The stay-at-home orders work. Discontinuing classes and stay-at-home orders work. What this is doing is it's decreasing the burden of disease, decreasing deaths, is allowing us to buy time to replenish PPE, development of a vaccine, development and use and research for antiviral medications. It's kicking the can down the road. It's the flattening the curve. Flattening the curve doesn't decrease the total number of cases until you get treatments and vaccine, and that's at a future date, and that's what we hope for.
One more question?
Governor, there's a group or a coalition, if you will, of people who are concerned that your executive order on no rent payments and no mortgage payments isn't going far enough, because once that order is lifted, they have 3 months of back payments and rent. So they're asking you to extend that and just erase people of their debts altogether. They said they wrote you a letter about this. Have you considered that, or is that even a possibility?
We've had no discussions about that. I have not seen the letter, so when I do, we'll have those discussions.
Thank you.
Can we get a quick picture of that before you take it away?
We possibly get that as a picture. Is that a photo that you guys have?
You mentioned that in the interview.
Yeah.
Last week, and I was telling my friend about it, and he was like, that looks like a tiny chamber. So let's see.
Let's see. I gotta see if I can figure out how to get the shell.
But I'm gonna reach out. Just down the road. Probably not, but.
Wait, can I grab one more picture of that? Can I get one more shot of that? Would you mind? You're fine, thank you. Trying to get everything on hook so I can.